Welcome to the meeting. I apologize by the little inconvenience in the connection with some speaker. Now we have the opportunity to introduce Dr. Ten Xin. Dr. Dr. Ten Xin from China talk us by clinical feature and predictor of outcome of COVID-19. Do you want? Thanks.
Okay, let me see. Can I start?
Yes. You can start. Okay.
Okay. Okay. Good afternoon, everyone. First, thanks very much for Dr. Jody Vela's invitation. I'm a physician coming from Wuhan. I'm a director and a professor of Department of Infectious Disease. Since the beginning of this year, I worked in the front line. So when I get this invitation, I think it's my responsibility to share my experience with the SPAN physicians. I hope my experience can have some helps for you fighting with this disease. So I will give this talk, clinical features and the predictors of outcome. Well, this is the data I got from the WHO website today. You can see that the confirmed case, will reach to 1 million soon, and the death is over 40,000, and the mortality is 4.9%. In the past 3 months, and China is struggling with this disease, and in China, the mortality is about 4%. So somehow the mortality for this disease is really horrible, and we need to work together to fight this disease. So for this disease, and both of children and adults are susceptible to SARS coronavirus 2, and it can transmit it from person to person. And the major transmission pathway are airborne and close contact. And actually in China, they did an investigation for children's infection, the SARS coronavirus 2 infection, and most of children have the exposure history to close contact with the infected family member. And also for person over 65 years old with underlying disease are high-risk group. And based on data from China, about 8% are mild cases and 20% are severe cases. And 5% of severe cases are critically ill patients. Okay, here just show you the symptoms. Actually, these symptoms are hospitalized patient symptoms. And normally the patients have fever, fatigue, cough, and sputum production, and headache and dyspnea and diarrhea. But I think we have to pay attention that actually some patients, they didn't admit to hospital, and some of them, they don't have fever. Okay, we called him the asymptomatic patients. Actually, this group patients, we have to be very careful for that. Okay, for the laboratory results, this is my personal experience. And for whole blood count, normally the white blood cell is normal or decreased, and the neutrophil is increased, and the patients have lymphopenia. And normally the monocyte is normal. And for the evaluating the inflammatory, we can see the patients have high CRP, high IL-6 and 10, also have high SAA. Procalcitonin normally is normal when the patients are admission, but in the later phase, if the patients have co-infection, it will increase. And for the lymphocyte subset, we observed that the patient's absolute count of CD3 decreased. And we further analyzed that, we found that CD8 significantly decreased. And for the DSC test, the D-dimer and the FTP increased, but PT and FTT are generally normal. For liver function, it's less affected. We just observe slightly elevated ALT, ST, GGT, but for severe patients, the albumin decreased. And for the renal function, if the patients develop to the multi-organ dysfunction, and we can say the creatinine increased. And for the others, we saw the LDH, ferritin are increased. Okay, another very important examination is the chest CT image. Okay, you can see these two patients, both of them took the CT on day 10, and they have fever for 10 days. The only difference is for patient 1 is younger, 34 years old, and patient 2 is 71 years old with hypertension and diabetes. And we can see the CT image features. And for the patient 1, in the right lung, you can see the very typical ground glass opacities. But for the patient 2 is just the white lung. And the patient 1 survived and the patient 2 died. Okay, these slides just come from my colleagues in Department of Radiology, and they analyzed the 21 COVID-19 patients, and they analyzed the CT score, and you can see here, and the highest CT score is around the day 10, and further they separate the patients into the different stage 1 to stage 4, and the highest score focus on the stage 3, which is the 9 to 13 days. Okay, and in clinical, we saw some patients, they are non-lesion just progress very rapidly. Like this one, and day 5 is okay, and day 15, and there's some progress. In day 20, you can see enlargement of lesion. Okay, of course, we also saw some patients, the lung lesion get improved. This is my patients, and this is day 11. You can see the lesion on both sides and absorbed on day 16 and on day 22 and improve a lot. And day 29, just very few. Okay, in China, we classify the COVID-19 into 4 types. For the mild type, normally the patient has very mild symptoms with no signs of pneumonia on chest CT image. And for the common type, we saw the patients have fever, but not all the patients have fever, but they have the respiratory symptoms and very typical viral pneumonia on CT image. And for the severe type, we will observe the patient's respiratory rate is over 30 beats per minute, and also the patient's oxygen saturation is less than 93% in the resting state. And for the index of PaO2 over FiO2 is less than 300. And of course, the chest CT results is very important. If the lesion increased more than 50% with 24 to 48 hours, we have to be very careful for that. And for the critically ill type is the patients on the basis of severe type. If the patients have respiratory failure and requires mechanical ventilation, or the patients have shock or a multi-organ failure, or ICU care is needed. Okay, for the predictor, I think the very, very important thing is the timeline and the symptoms. So here, just show you, okay, normally the patients come to hospital on day 7, and on day 8, they develop to dyspnea. And on day 9, the patients start to have the ARDS, and around the day 10 to 11 has the intensive care unit. So I always told my residents, okay, when you saw a new patient, always ask the patients, this is what is the day after illness onset. If the patient is on the early day of sickness week, which means that around 8 to 12 day, you have to be very, very careful. You have to watch the patients closely, because the patients may have great progress during this time. And for the laboratory results, I think the lymphocyte is very important. So for the severe patients, and the lymphocyte continue to drop and keep at a lower level, and it cannot be back to the normal level. For survival patients, actually, the lymphocyte can be back to a normal level. And another important is the neutrophil to lymphocyte ratio. Sorry, should be higher. Should be higher. If it's higher, and then the outcome is bad, is worse. So I think neutrophil over lymphocytes actually stand for the inflammation and immune function. So this is very important index. And also we observe the CRP if it's very high on admission, and the DIMA is very high on admission. Of course, for the CT image, show the rapid progress. Okay, and another predictor is age. If the patient is over 65 years old and patients have the comorbidities, and for the patients in the ICU, and we observe that the top 3 diseases are hypertension, cardiovascular disease, and diabetes. Of course, we saw some patients with COPD and malignancy and chronic liver disease. So I talked about clinical features and predictors, and how do we use that in the practice. So actually, this is a real-world situation, and we have a shortage of medical staff, and we have such amount of patients. But actually, some of them non-COVID-19, and some of them just mild, and some common type, and some potential severe patients, and some patients are really severe and critically ill patients. So what we do is, at Fever Clinic, the first step is we need to exclude non-COVID-19 patients. So we will ask the patients to finish the following test: the routine blood test, and the CRP, and the chest CT scan. Yeah, we don't do the chest X-ray. And also we do the RNA and antibodies detection, but in the beginning of this year, we don't have the antibody detection, and we start to have the RNA detection in the end of January. And also we need to do the to exclude the flu RNA test. Of course, we need to exclude respiratory related virus detection. So in this case, we can divide the patients into the non-COVID-19 and COVID-19. Here, you can see we put the clinically diagnosis case, because for some patients, they have very typical symptoms and very typical pneumonia change CT image, but the tests are negative because the RNA test is only 50% sensitivity. So we will treat all this clinically diagnosis case as confirmed case. And then we need to find out who is mild patient, and we will transfer the mild patients to mobile cabin hospital. So this is our criteria. So if patients is younger than 65 years old and can take care of themselves, and the mental is stable and without severe underlying disease, and no fever or low fever, and the oxygen saturation is over 95% in the rest status, and if neutrophil lymphocyte ratio is less than 3, or absolute lymphocyte count is over 1200 per microliter, and the CRP is normal or mild elevated, so they will send to mobile cabin. But if the patients in mobile cabin, they have fever, or the saturation, the oxygen saturation is down, and we will send them to isolation wards. Okay, and so for patients in the isolation wards, I think our duty is we need to identify the potential severe patients. Why I say like this? Because for severe critical ill patients, you will pay attention on him, because you know, okay, he's sick, he's very sick. You need to ask a nurse to always observe him. But for the potential severe patients, they may progress very fast and you ignore him. But for the common type patients, normally, yeah, they are fine. So this is what we observed for the potential severe patients. Okay, even though these patients, okay, oxygen saturation is higher than 93%, but they have the underlying disease and the age is 65 years and have fever more than 7 days. And if we saw the CT lesion is more than 50%, and also the neutrophil lymphocyte is high and CRP significantly elevated and D-dimer elevated. So you have to pay attention on these patients. Yeah, very, very important, I would like to say. And this is the principal treatment of COVID-19. I will not go into the detail, so include antiviral treatment, antibiotic treatment, management of underlying disease. And for the severe patients, we will give the respiratory support and immunomodulatory treatment, and of course, supportive treatment, and organ protection and anticoagulation treatment. And for critically ill patients, we will have the CRT and the respiratory support. So I would like to say the anticoagulation treatment is very important. So last, I will give a medical history, a case report. Actually, I think we have successfully treated a lot of patients, but being a physician, I would like to share some unsuccessful case because it will remind us what we should do and we can do better in the future. So this is male, 71 years old, admitted on February 13, and he started to have fever on February 5th, and with temperature up to the 39 degree, and the chest CT showed were pneumonia, and the RNA detection was positive, and he has medical history of hypertension and coronary heart disease. So actually, this patient has some risk factors. As old man and with fever and pneumonia and some underlying disease. Well, but these patients gave us some how to say. So you can say the chest CT. Okay, so it's not too bad. Okay, because on February 13th, we accept 64 patients with one night. So we have a lot of work, and 19% of patients are older than 65 years old. So what we do is we just do the CT screening very fast. We will say, okay, which patient's CT is worse, but this patient is not, it's not too bad. And then for the laboratory results, you can see that, okay, for white blood cell, well, it's normal, and the neutrophil is normal, and for lymphocyte is low, but not too much low, because we saw some patients, lymphocyte is much lower than these patients. Okay, the CRP is high, and the PCT is normal. Well, but these patients, okay, the admission day is on day 8, and then on day 9 and day 10, the patient's temperature didn't down, and it's up to almost 40 degree. And so after patients come, let me say, on day 8 and day 9, the patient's oxygen saturation could be up to the 19%. So because we are still waiting for some results, so we gave the moxifloxacin and the antiviral treatment with Apidol and ribavirin, and also we gave the human immunoglobulin. And then we give the steroid on day 11. The patient's temperature is down to normal, but the heartbeat is very fast and sent to ICU, and the patients die very fast. So this is the oxygen therapy we give to patients, and we give the nasal catheter oxygen inhalation and mask oxygen inhalation and high flow and non-invasive ventilation.
Excuse me, Dr. Zheng.
Well, we know
2
that.
minutes. 2 minutes.
Yeah, I'm done.
Please.
I'm almost done. Okay. We know that it will be very tough for us to fight with this disease, but I would like to say we will win. I will show you. Okay, this is a couple, and this young man mom died, and when he come, his platelet is very low, and this lady and her husband passed away, yeah, because of this disease, and she belongs to the severe case, but all of them are survived and discharged. So I think spring is in Wuhan right now. I believe the spring will be everywhere in the worldwide. Thank you for your listening. I'm done.
Thank you, Dr. Shin. I have two questions. The first question is, are there any clues to distinguish if pulmonary infiltrates represent primary pneumonia or immune-mediated injury?
Sorry, I need to catch your question.
Are there any clues to distinguish if pulmonary infiltrates represent primary
You mean
viral
the other pneumonia? You
okay.
mean the distinction from other pneumonia?
Or immune-mediated injury? Do you have?
Or
It's possible
you mean that for
distinguish between primary viral pneumonia and immune-mediated injury?
primary pneumonia?
Or immune-mediated injury in lung?
You mean that how can we exclude the patients, the pneumonia coming from the other factors, right?
Yes.
Actually, I think the our radiologists they are very experienced, and because the CT image are very special, yeah, very special, and of course we need a yeah, I just mentioned that if we give the diagnosis, we have to exclude other respiratory related pathogen, you know, and like flu or others. And also we have to combine with the RNA and antibody tests.
And the last question. Some societies say that anosmia and ageusia are symptoms of this disease. Should be included in possible symptoms of COVID-19 in order to prevent the spread?
Can you repeat your question?
Yes. Some societies say that anosmia and ageusia are symptoms of this disease. Should this be included in possible symptoms of COVID-19 in order to prevent the spread? Anosmia
or
and
you mean the
ageusia.
asymptomatic patients? You
Yes.
mean the asymptomatic patients?
No, patient with
You mean
anosmia. Patient with anosmia.
Patients with
Anosmia
patients
and ageusia.
Patients with
Anosmia.
Patients with what?
Anosmia and ageusia.
Anosmia.
Yes.
Sorry, I didn't catch it. Yeah.
Okay. Another question. The last question. Is there a biomarker which helps to predict bad development in hospitalized children? Biomarker.
You mean is there any marker for what?
Hospitalized children?
For children. Okay.
No,
for children,
for
actually,
children.
is there any predictor marker for children?
For children, for hospitalized children, for the bad outcome of hospitalized children.
You mean is there any predictor for outcome of hospitalized children?
Yeah,
is correct.
Children, yes. Okay.
Yeah. Actually, I think the outcome for kids, they are good, and my colleagues told me that they are only very few children die because they have some underlying disease. The underlying
Okay.
disease.
Okay.
Actually, for
Thank you.
COVID-19 itself, actually doesn't cause the patients die.
Okay. Thank you very much, Dr. Shin.
Okay, you're welcome.